Just one quick thing. So thanks so much for that, I'm sure very painful case, looking back on it even. So just as a curiosity, as a show of hands across our panel here, in an otherwise patient who can tolerate an open procedure with a groin cut down, how many would still try to tackle a common femoral disease endovascularly? And how many would refer it to surgery? Okay.
I think that if I cause the complication from an angioceal device, I'll certainly try and rescue that myself. If I'm treating someone who I think is a poor surgical candidate. But otherwise, if I see common femoral disease, especially if it involves the ostium of the profunda, they just benefit so much from endarterectomy and patch angioplasty.
We do have one randomized control trial that showed no difference between endovascular versus open endarterectomy. So, small trial, 117 patients, but I think it depends upon your patients and really kind of what you're up against. The gold standard by far is endarterectomy. That being said, I think that case with the stent all the way up to the ostium makes a big difference. Our surgeons will tell you that they'll cut the stent out just to be able to get some proximal control with the loop, and I think it's a real issue. If you're going to compromise their flow or their ability to loop the vessel, I think go up to the common femoral. I think you're better off. And I think now with Supera, I think it's a bigger issue. I think your flexibility is pretty damn good in the common femoral.
It's interesting. So even in advance, towards the ounce of prevention, worth a pound of cure, for closure devices, I preferentially use Perclose, even though they're a little annoying, just because if something bad happens, it's the type of thing we can commonly fix endovascularly. With angioseals, I'm just sometimes a little anxious about where the collagen plug actually is as you're working. Are you pushing it down? Is it somewhere else? So from that standpoint, I agree with the group. I'll try, especially if it's something I caused. I, in advance, try to make sure it's something I could preferentially fix.
For particularly hostile groins, for third or fourth time redos, we've have almost a primarily endovascular approach just because it's kind of so hard to get back in. And I agree with the enthusiasm for EPDs in those settings. You really do have to be comfortable with making sure you don't chew it up by mistake when you're atherectomizing and things. But I will also say that, having pulled a lot of Percloses and angioseals and everything and its brother out of there, like, gosh, it's not all that hard to take it out with surgery.
Sure.
I think I want to add that for common femoral, it is very important, in my opinion, to make a statement and then not clarify it with a multitudes of caveats. Because it is, whenever I've heard people say I take on common femorals, the second line is actually a select cases of careful case selection. So I think I do want to be careful about saying that what should be the generalized approach to it versus have I done it? And those are two very different questions.
I think it's very operator specific, and I think just if you're going to take on common femoral occlusions, that is where your IVUS is very essential for true lumen. The last thing you want to do is shut down your profunda. Then you're really in a world of pain.
And from a pure system...
Question from the audience.
So I can tell you, really, I'm, again, a vascular surgeon. I do a lot of endovascular intervention, perhaps 80–85% what we do. One area that I think nobody should do unless there is no surgical option and nobody else there to do is the common femoral artery with the case that you showed. It's exophytic, very bad area. You'll embolize. There is no patient, in my opinion, except the recurrent, you should try to avoid. And on those cases, the occlusion usually is not the exact occlusion we see as a de novo occlusion. You can stent those by kissing balloon. We do it a lot, 8 French sheet, and we go on both of them, and we dilate them, but we don't stent, and it works. But to say because I can cross the lesion in the common femoral with that dirtiness and ugliness, I should do it, I really, this is a very bad message.
I think
we are sending to everybody, only certain cases, common femoral artery, you should do.
So
not every case.
Not every case. That being said, I think you have to respect the RCT data that says that there's no difference there. So I think it's a personal opinion and it's a comfort level, and I also think it's an experience factor. I would never do any of these within your first 5 years of experience. Absolutely, under no circumstances. And the key thing, more than anything, is to preserve a surgical inflow so that you have if worse comes to worse, everything goes down. You have a place to tie into in the common femoral and a place to go distally.
Excellent points, excellent points.
A quick kind of related question for the panel. You know, in some of these acute limbs like we talked about and thrombotic occlusions like we talked about, what are we doing with medical therapy afterwards, you know, especially for the acute limbs? I know in the days of Compass Peripheral, I now think about it, at the very least, getting these folks on like the low-dose anticoagulation strategy when it's safe from a post-procedural standpoint. I was curious if someone has like stent thromboses like we've seen, are you then putting them on full anticoagulation, and if so, when?
I actually put them on full anticoagulation with any thrombus for at least a month to 3 months.
Yeah, after, for me, if I'm lysing anyone, I'm putting them on at least a 3-month course of anticoagulation and
With dual
following with
antiplatelet
close surveillance.
With dual antiplatelet too? So they're on
If they can tolerate it, if not, Plavix and anticoagulation.
Yes, and take the aspirin off. That's
Yeah.
exactly what we do.
I actually do full dose anticoagulation if it's a super complex, long SFA intervention as well for at least a month. I think Plital is helpful in those patients too. So I'll do Plavix, Plital, and anticoagulation before I do aspirin, Plavix.
There's actually been some data back in the bare metal stent days of Plital reducing in-stent restenosis, so it's another option to use.
I think we're going to know a lot more when the Voyager trial's done, which should, I'm hopeful that it's presented either at AHA or ACC based on the recruitment and data events and event rates.
All right, on that note, lots of controversies, I'm sure more for us to discuss. Send the common femorals to us. We can clean out with a little tiny incision. But anyway, thank you so much to the panel, and we love doing it. And thank you so much to the crowd.